Good evening, everybody. Hope you are doing well. Nate Lighthizer here, faculty member at the Oklahoma College of Optometry in Tahlequah, Oklahoma. It is my absolute pleasure to share the virtual stage with Dr. Bradley Grant. Bradley, welcome. Looking forward to this, buddy.
Absolutely. Pleasure to be here. I'm in practice in Central Illinois with Vision Point Eye Center. Dr. Lighthizer's in academic and education. I'm in private practice, so hopefully we can give a good, well-rounded view of things to everyone.
Yeah, I love that. Different perspectives, again, whether you're in academia or private practice, on just the tremendous role and utilization of ERG, something that has evolved tremendously over the course of the last even 10 years, how much it's evolved and changed. And we're looking forward to chatting and to going into that detail for you guys. So let's move on to the next slide here. There we go. So, first question is, do you think testing structure and function is important in your ocular pathology patients? You guys think of this, and you can answer it via the chat box if you so desire. But when you think of our glaucoma patients and our diabetic retinopathy patients and, all of our ocular pathology patients, is testing structure and function important to you? I asked this question last night. I was on a webinar with the Saskatchewan optometers up in Canada, and there was 50 docs on that webinar, and I polled the audience. If you've been to my lectures before, I like to poll the audience. We don't have that going tonight. But I asked them this question. This exact question led off my lecture last night about diabetes and ERG and things like that. And 100% of them, every single one said, yes, we think testing structure and function is important in your ocular pathology patients. Bradley, you do this every single day, don't you?
Every single day, multiple times a day. Absolutely.
Yeah. Yep. And again, glaucoma, you guys think of glaucoma. We do OCTs, wonderful at structure. You look at the nerve that's looking at structure, but we've got visual fields as well that look at function. There can be limitations to visual fields, but regardless, looking at structure and function gives us the best, most complete picture of what's going on in that ocular pathology patient. So moving on here. Okay. So let's talk on, the journey to standard of care for functional testing. This has been an incredible journey over the last, again, 10, 15, 20 years. I took over our electrodiagnostics clinic in 2010. I'd like to think that's not that long ago, 2010, 15 years ago. And ERG was done for cone dystrophies and retinitis pigmentosa. It was this thing that was in an academic center, an ophthalmology training facility, a research center. It was by no means standard of care in diabetes or diabetic retinopathy or glaucoma. And you talk on diabetes and diabetic retinopathy, it's amazing that this past year, the American Academy of Ophthalmology added ERG to their preferred practice pattern guidelines for diabetic retinopathy for both diagnosis and disease management. Disease management, what does that mean? Following them for potential progression or hopefully stability. Again, it's now in the preferred practice patterns ERG testing because of the functional aspect that it brings. Research study published by Ophthalmology Science identified the RETeval as the strongest predictor of DR progression within 1 year. I want you guys to digest that point number 2 there. Of all of the things that we have, fundus photos, and OCT, and OCT angiography, and fluorescein angiography, the strongest predictor of whether your diabetic patient is going to progress or not progress, remain stable, was the diabetic retinopathy score on the RETeval. Again, we'll go into more detail on that in just a little bit. And there's an initiative called the Mary Tyler Moore Vision Initiative, sponsored clinical trials conducted by the Diabetic Retinopathy Clinical Research Network. And again, the handheld ERG, the RETeval ERG, was selected for its potential to measure retinal function as they seek to augment the current guidelines for detection and staging of diabetic retinopathy. There's a lot of important, exciting stuff going on, research and guidelines and recommendations and protocols because of this wonderful device. So again, let's move on to the next slide here. And this is, again, going into detail of that, again, that study, that point number 2, they looked at a lot of different measures. Again, if you contact LKC, they will give you this study. And again, there's about 40 different metrics that they looked at. In fundus photos, there was a couple. OCT angiography, there was quite a few. ERG, there was quite a few. And fluorescein. And again, the strongest predictor of will they progress to sight-threatening complications was the DR score greater than 26.9, and second was a DR score greater than 23.5, better than the OCTA, better than fundus photos, better than ultra-wide field fluorescein angiography. Again, this is going to give you the best data on whether your patient is more likely to progress or they are less likely to progress. Again, important stuff. So structure and function in ocular disease, this is, again, not new for you guys. You take a look, and we do this next slide all the time. You guys take pictures. You bring up a fundus photo. If I was to ask you, Bradley, in your practice, what are the most common ancillary tests that you do in diabetes and diabetic retinopathy? I bet this would be one of them, would it not?
Yep. Fundus photos and OCT. Just all the time looking for structural changes.
And you think you do a DFE probably as well. And when you think of DFE and OCT and fundus photos, that is structure, structure, structure. DFE is structure. Fundus photos, you're looking at structure. You look at OCTs, that's looking at structure as well. You're not going to hear Bradley or I say that ERG is going to replace fundus photos or replace OCT or replace ERG, or excuse me, replace your DFE. It complements it. It pairs with it so beautifully. You've got structure and you've got function as well. So continue to take your fundus photos, whether they're posterior pole or whether they're ultra wide field images. And then you look at the OCTs, on the next slide. Continue to do your OCTs. You do your macular OCTs. And this technology has evolved and changed from images that look at the top left. And now we have high definition OCT, and you keep moving forward here. And we've got OCTs that have gotten better and better and better. And guess what has also gotten better over the last 10, 15, 20 plus years? ERG has gotten better as well. So you move forward here, functional tests. You guys believe in functional testing. You can kind of go through all this slide here, kind of bring up all this build. You believe in functional testing. We believe in functional testing as well. And there's some functional tests out there. The problem is most of them rely on the patient to respond to this. The most common functional test that we probably utilize is visual field. Okay, it gives us great functional data in our glaucoma patients and maybe other conditions as well. But you've all had a patient that struggles on a visual field. It relies on the patient. It is subjective. Again, visual acuity is standard of care. You got to do that. Contrast sensitivity. Do you do that in diabetic patients? Color contrast testing. Do you do that in diabetic patients? We have some better and better tests out there now, but again, subjective. Visual field testing, as we said, Amsler grid, preferential hyperacuity, dark adaptation. Every single one of those requires the patient to click a button or respond. They are subjective. ERG objectively looks at function. The patient doesn't have to respond to anything. They don't have to click a button. They don't have to make a choice. All they have to do is be able to sit there and basically hold their eyes open and hold steady on fixation. It is an objective functional test. Bradley, anything to add on this slide? Our functional options.
So the only thing I would add is that when you talk about integrating technology, and most of these tests that we have listed here are not necessarily performed by us as the doctors either. They're performed by our staff. And so objective testing is easier on our staff as well, right? And you can trust the reliability sometimes higher as well, right? You're not worried about patient feedback in the same way in terms of reliable test results. If you have the ability to open the eyes and you have the ability to get the sensors placed in the right location, then you're going to have an accurate test.
Yep. So again, remember, objective, functional. Let's go back historically. What do you think of when you think of electrophysiology? ERGs and VEPs, I always make the joke, as they put these pictures up here. You guys remember that room in the back at school? Whenever you graduated, whether it was 5 years ago or 35 years ago, you had this room in the back, and there was no windows in that room, wasn't there? There was no windows. It was dark back there. Maybe a red light, and there's wires everywhere. And you didn't want to go back there because you didn't know where those wires would be hooked up to you. ERG was this, oh yeah, that's the research thing, the multifocal ERG and the EOG and VEP or VER. It has completely changed, as we said earlier. Again, I got this picture off of the internet. This is like 50 years ago. We're reading minds there. It has evolved from this, and it's
Dr. Nate,
huge. Yeah.
would you say, if you go back a slide, please, would you say that patient is half smiling right there? I mean, that's, I think that I like the most about that picture. She looks happy to have that on her.
She could be happy. That could be a smile. She could be dead as well. We don't even know in this way. Yeah. So it's so evolved. And it used to be a huge test, and it used to be a crazy expensive test, and it used to have to be dilated for it and dark adapt the patient, and it's completely evolved. And if we move on to the next here. And now we have handheld devices, and both Bradley and I have this in our clinic, and this is an incredibly powerful tool that you have in the palm of your hands that you can take right to the patient. And I have been surprised at how much patients have loved that, to go take it right to them in the exam chair and explain it to them what's going on. This new test, excuse me, this new test that we have, which I call the EKG of the back of the eye, which we'll get into in just a little bit. But they love when you can bring it right to them. Again, it's accessible for them, easy to integrate. It's impactful, as we'll go into, and a smart investment. Bradley, you're in private practice. The flow of this, of being able to take the test right to them, I'm sure that's been impactful in your practice.
It's huge. And one of the limiting factors that we all have in private practice is that, space is a premium. And so if you can have an instrument that can go to the exam room, we perform the test in the exam room instead of having to have another pretest room or another instrument in a room that's already being used for visual fields or OCT or another test, right? You don't need more space. That's a tremendous benefit whenever, space is as expensive as it is these days.
I want to under the impactful and comprehensive on the right side of the screen, first bullet point, multiple protocols. For you guys out there that, go, man, I'm a little overwhelmed. How would I even know how to use this? This makes it so simple. You have protocols that you follow. Most common reason that we use this is diabetes, diabetic retinopathy. And there's a diabetic retinopathy assessment protocol, the DR assessment protocol. So you choose that protocol and it lays it out for you perfectly. It tells you exactly what to do as you do this test in the right eye, and then the left eye. It takes about a minute in each eye. So it has a protocol for that. Okay, I'm going to do this in glaucoma, something called the photopic negative response, which tests ganglion cell function. You think glaucoma, I select the photopic negative response protocol, and now I'm testing ganglion cell function, as I just said. I got another retinopathy. It's not diabetes related. Maybe it's a vein occlusion or hypertensive retinopathy, or if they got some mid-peripheral hemorrhages, and I want to get a good idea to test how's this retina functioning. I would do the Flicker 16 protocol. Those are the three most common protocols that we do. So you memorize those three things, and those are your three main protocols. And there's dozens of other ones as well. But again, implementing this, you're not going to start with the super, super rare ones. They're there if you want to dive into rod cone function and different steps, but that's diving into the electrodiagnostics weeds. You've got really easy, ready to implement protocols for diabetes, glaucoma, and other retinal stuff as well. So I think it makes it very impactful, and it's very comprehensive as well. So again, clinically valuable, smart investment 92273 is the code. This is a slide for Bradley. This is really a great slide, for a win for patients and practices. When you think of something in private practice, it's got to meet a lot of these things. Does it do something others don't? Is it clinically impactful? Bradley, when you decided to bring this in, you're in private practice. I'm in academia, where we like to have kind of everything to teach our students and residents. How did you decide to bring this into your practice?
So when we were making the decision, we would look at our EHR to see how many patients we have with a certain diagnosis. And from a diabetes standpoint, it's really somewhat of a no-brainer for anyone when you think about, there's almost 100 million individuals in this country that have diabetes or pre-diabetes, right? I mean, it's an incredibly large number. So that one you don't really have to run the data on, but we pulled up, ICD 10 codes for those in our practice, active patients with diagnoses that would, be something we would want to run this test on. And the numbers were quite astounding in terms of the additional clinical benefit that we would gain. From a private practice standpoint and a profitability perspective, I think it is important on the previous slide where it listed, there is a CPT code for it. And so it is reimbursable by insurance. There are hundreds of ICD-10 codes that apply, but also it is billable with other codes on the same day. So we go back to the beginning, we talk about structure and function, right? We're running this test when we want all of the information together. We're not getting just exclusively functional data, right? We're getting OCTs at the same time as we're getting the ERG. And so we have complementary data. We might be getting photos in ERG, and even you can do photos, visual fields in ERG. You could do subjective and objective functional testing on the same day. And from a coding and billing standpoint, that makes it much more simple than other procedures.
Yeah. So does this do something our other technology doesn't? Yeah, it objectively looks at function. Tell me the test that you have in your office that objectively looks at function. The answer is we don't have one. Now we do. Does it provide clinical information? It is our best predictor of progression in diabetic patients. The literature is very clear on that. It's easily incorporated into our practice. Is it patient friendly? We already answered that. You can take it right to the patient. I would have argued a couple of years ago it was leading edge, and it's shifting towards standard of care as it's now in the preferred practice patterns. And Bradley said, again, profitable practice building as well with a CPT code and reimbursement $120 to $130, depending on where you're at there. So we're moving on here. And so again, definitely a win for the patient. ERG in general. Remember, this is a flash ERG. It's a flash or flicker ERG, flash of light going into the eyes. Because of that, a flash of light, when I flash a light in your eyes, it would go superior, inferior, nasal, and temporal, central, mid-peripheral, and peripheral. That flash of light is going to go all over the place. And for that reason, your flash ERG, your flicker ERG tests overall retinal function. It might not pay attention to small retinal lesions. This would not be my test of choice to diagnose plaquenil toxicity. The earliest signs of plaquenil toxicity are better picked up with a multifocal ERG or an OCT or maybe even a visual field. So think of this as overall, from top to bottom, left to right, central, peripheral, mid-peripheral. How's the retina working? How's the retina functioning? How is the retina, again, working overall? So it's a flash ERG. Again, we move on here to the next slide. And we have other functional tests. Visual acuity. I tested that numerous times in the patients that I saw today. And visual acuity tests your central 2 or 3 degrees. Again, so in diabetics, I want to know overall how it's going on. Your patient that has mild NPDR or moderate NPDR that has no macular edema, they may be 20/20. I asked that question last night to, again, Saskatchewan, and I said, your patient that has mild NPDR without macular edema, what's most often their visual acuity? And they said 20/20. And they said 20/20 there. So moving on to the next slide, visual acuity, center 2 to 3 degrees. OCT is right here, is, again, wonderful structural test. That central area around the macular, the optic nerve. Okay, moving on. Your visual field, 24-2 visual field, subjectively looking at function in this area. And lastly, you go to the flash ERG, and it's everything. Flash ERG from top to bottom, left to right, is everything. This is an overall global test. Move on to the next slide. Overall global test of retinal function. There it is, right there. And again, gives us a big picture, big picture. How is the retina functioning? Okay. All right, moving on. And as Bradley said, again, our CPT codes, 92273, 92273. These are your 3 most common protocols. I mentioned them already. The DR assessment, by far in our clinic, the number 1 protocol that we run, the diabetic retinopathy assessment code. Number 2 for us would be the photopic negative response, that one on the right there. For, again, your glaucomatous optic atrophy, optic nerve issues, and then everything else retina would be your flicker 16 or your flicker 32. Again, those are your most common protocols. I think there's close to 60 different protocols on this. Again, you can dive into the weeds if you so desire. But again, this is where you're going to start. This is the nuts and bolts of what you're going to do on a day in and day out basis. Bradley, would you agree?
100%, and would be the same in that order for us. DR protocol first. We do utilize the PHNR protocol quite a bit for glaucoma suspects, just to give that extra piece of information if we're potentially on the fence of treat or not to treat. And then I would say we run quite a few Flicker 16s with hypertensive retinopathy. We do see a lot of that even in the absence of coexisting diabetes. And we like that test for, one, the value that it gives us, but also the education piece in terms of the patients, because I think there's a lot of individuals that, you know, couple mentally diabetes and problems with the eyes, but not so much hypertension. And so it gives us some ability to have more valuable conversations with those patients as well.
Yep, exactly.
Dr. Lighthizer, this is Gail. I have a question here in the chat that we were just talking a little bit about workflow, so I thought I would just bring this up. Yep. So one of the doctors is asking, do you baseline VSP iMed exam routine one day and have the patient come back for medical, like for diabetic or glaucoma, another day?
So I'm going to kick that to Bradley in private practice. Did you hear that, Bradley?
Yes, I did. So if you have, and this is our practice, this is how we do it. If you have diabetes, you are a medical exam, right? So we're not, you know, with the exception of coordination of benefits for VSP, we're not billing iMed or VSP routine vision for diabetes. And so we're already billing that as a medical exam to their medical insurance, and we have a waiver that they sign to understand that on the front end. So there's different schools of thought on, do you do a baseline for anyone with diabetes to establish a baseline DR score? I think there's great value in that. Others might say, well, they'll do an ERG once there's any form of diabetic retinopathy. I think that's truly decision that's based on particular practices preferences. But in specific answer to your question, no, we don't bring them back. But that's because if they have diabetes, they're a medical exam to begin with.
Bradley, what ICD-10 code are you using for a glaucoma suspect? You know, it's that one may be a little bit of a gray area. You could go either way on that one. You know, I believe there's strong utilization in terms of a clinical value of that patient, that you're right on the fence, and you could go either way. Is this glaucoma? Is it not? To get that PHNR to give you ganglion cell function data. Is what ICD-10 code are you using, or are you just saying we can't bill it and this time just using it for the clinical value?
So a little bit of both. I mean, sometimes there's not a great ICD-10 code because, you know, your traditional open angle borderline suspect findings is not a billable code. I'll say those that I'm on the fence on, usually where it's pallor exceeding cupping. And so then I'm using a code that has some kind of optic nerve pallor, whether it's secondary optic nerve pallor or secondary atrophy or something like that. There's also a code that's, I don't know the number, but other disorder of optic nerve. And so sometimes if I'm just not sure, again, optic nerve looks funny, maybe pallor, maybe not 100% sure if maybe there's, you know, ischemic optic neuropathy involved, we might use that one. And I just make sure I'm descriptive in the plan underneath that assessment to just describe why we wanted that test. So, I mean, there's a few of them, but it's not 100% straightforward as glaucoma suspect is a billable diagnosis.
Yep. All right, let's move on so we make sure we can get to our cases and interpretation. So let's talk about interpretation. How do you interpret these ERGs? Let's not make this too complicated, okay? You take a look at this, and this is a Flicker 16 protocol, some other retinal conditions, non-diabetic, but we've got the right eye is on the left side here, and the left eye is on the right side, okay? So don't overcomplicate these things. You know, this is the EKG of the back of the eye. That's what I tell patients. I walk in, and I go, Mrs. Jones, have you ever had an EKG before? And it's amazing how every patient has either had an EKG or they know what they are. They all know what an EKG is. Said this is called an ERG, which is an electroretinogram. It's the EKG of the back of the eye. We're going to flash some lights in your eyes, okay? We're going to flash some lights in your eyes, and it's going to tell us how is your retina firing, how is your retina functioning, basically how is your retina working. Similar to that EKG, how is your cardiac system functioning? How is it working? So, and none of us are cardiologists on this call. Let's kind of go to the next build here. But all of you know that looks like probably looks like a good EKG there. It's got strength. It's got a normal pattern. It's got a normal speed. Okay, looks good. And again, none of us are cardiologists, but if you go to the next one, I bet all of us can recognize that that is not a normal EKG, is it? That one at the top, obviously it's flatlined and it looks much different, okay? Again, going back now, let's go back to the ERG and the previous one here, okay? Let's take a look at those bottom two plots here, okay? Bottom left and bottom right, okay? Those are the ERG waveforms. And we're looking at the height of those peaks and how quickly they happen. Again, the height of those peaks or those spikes and how quickly they happen, okay? You can see the qualitative data, no numbers on the actual waveform, those kind of lines and scribbles, the spikes there, that's the qualitative data. And I want those peaks to be nice and high, nice and tall. That's a strong response. That represents the amplitude or the strength of the retinal response, right eye and left eye, okay? That's the strength, okay? The implicit time is the speed. You want their retina responding strongly and quickly. Strongly and quickly. I always say this is analogous to your favorite sports team's athletes. What do you want in your favorite sports team's athletes? You want them to be strong and quick. And you want their retinal response to be strong and quick. I need it strong and quick. Again, the strength is the height of the peaks, and the speed is, are they happening quickly? There's a little cheat sheet in on the waveforms here. Notice this little rectangle. The little rectangle, that's where you want that first peak to land. If it's below that, that means it's a weak response. If it's behind it, that means it's a slow response. So you can't know what abnormal is until you know what normal is. That's a very, very normal ERG response here. You can see a lot of green. We haven't even went into the numbers yet, but very, very normal. Let's go to the abnormal response. Okay, let's go ahead. Not the EKG one, but there you go, right there. Look at the bottom. Look at those waveforms and how they're much weaker. Those peaks aren't as strong as the previous normal one we looked at. Notice the peaks are lower than those rectangular boxes, and they're behind those rectangular boxes. They are what I call low and slow. And again, we haven't even went into the quantitative data yet, the numbers that are above there that you can see all highlighted in red, but that would be an abnormal ERG. This retina is struggling. It's not handling that flash of light over 1 minute in each eye. This retina is dysfunctional. This retina is probably ischemic, and we need to change some things in this patient that has diabetes or diabetic retinopathy. Let's move forward here. Okay. So that's, again, just kind of the standard ERG interpretation. So let's, now that we have that foundation, let's move into the number one protocol that we utilize, the number one protocol that you're going to utilize as well, which is the DR assessment, the diabetic retinopathy assessment protocol. Again, this is your workhorse protocol in your diabetics. I start at the top. It gives you a DR score. The diabetic retinopathy score, the DR score, this is your one number that's been validated again and again and again through those studies that we talked about, the most predictive of is your patient going to progress or not. This score is like your golf game. The lower the number, the better. The lower the number, the better. And I want to see this in the teens. If it's in the teens, I consider that very, very normal. 20 to 23 is kind of borderline low normal. It may be okay, but it might be borderline. And the number you want to remember is 23.5. 23.5 and above. 23.5 and above is abnormal, with 26 and above, very abnormal. Again, being shown to be highly predictive of progression. So you take a look again, let's go back one more time, of normal. Go back to the normal at 15.1. Awesome. Looks great. I go to the qualitative data, those waveforms there. No, go back one. Again, there you go. The normal, nice peaks. Looks great there. But then let's go to the numbers. Notice all of these are highlighted in green. We've got the speed in the right eye in milliseconds, and the strength in the right eye in microvolts, and then the speed in the left eye and the strength in the left eye. Okay? Think of the speed as a 100-yard dash. 100-yard dash. If you run a 100-yard dash, do you want a big number or a small number? You want a small number. So I want these percentages under the milliseconds to be smaller. They go from 0% to 100%, and the smaller the number, the better. The smaller the number, the better. That's the speed of the response. The microvolts, okay, that's the second and the fourth green boxes here. Think of this as a weightlifting competition. If you enter a weightlifting competition, do you want a big number or a small number? Obviously, you want a big number in a weightlifting competition. So these percentages, I want them to be the higher is better. From 0% to 100%, the higher the percentage, the better. So it's the opposite of the implicit time, where the lower the percentage is better. Here it's the higher percentage is better. So this is just the numbers that give you the quantitative data compared to the qualitative waveforms that are below there. You know, Bradley, you look at this. Yes, go ahead, Gail.
Oh, Dr. Lighthizer, you can ask Dr. Grant your question, but one of the things that popped up in the chat is someone's asking, what is the difference between the waveform and the fundamental lines on the graph? So while you have the report up, I thought it would be good to answer that.
Sure. Bradley, you take a look at this, and this would be a normal overall ERG, diabetic retinopathy protocol, but you would agree the right eye looks a little bit better than the left eye. When you look at the peaks are a little bit higher in the right eye compared to the left eye, and look at the numbers, 52% and 50% in the right eye, and still a normal range, but low normal, 14% to 12%. So look at these numbers and follow them over time, correct?
Correct, yeah. And your DR score, fantastic at 15.1. I get asked quite a bit, where does the DR score come from? So there's more. So the DR score is composed of the age of the patient, the waveform data. So there we're looking at speed and strength, and then also the pupil at the very bottom. Again, as we remember that in forms of diabetic retinopathy, when there's ischemia to the eye, we're going to have reduction in terms of the pupillary response. So it's actually tracking the response of the pupil in coordination with those flashes of light as well. And that's part of what generates that total global score that gives a risk assessment. And so if you're wondering why that 15.1 is there in light of a little bit low and a little bit slow, even though within normal range on the left eye, that's because it factors in age, response, and pupil to give a good assessment.
And Carrie's question is perfect. Perform this undilated. The answer is you absolutely have to, because it looks at pupillary response. And if they're dilated, you're not going to get valid data. So this test, the number one protocol you run, the DR assessment, is an undilated test. And it needs to be an undilated test so you can measure pupillary function there. So you can't know what abnormal is until you know what normal is. And this is what I would consider overall a normal ERG, normal diabetic retinopathy assessment. Let's go to the abnormal one before we get to that question that Gail brought up. Here's an abnormal one. You take a look at this and immediately I go, all right, DR score is elevated, 24.8. Then I go down to the waveforms, okay, waveforms. And ask yourself, those waveforms, do they look more low or do they look more slow?
They're slow.
They are slow. Those peaks they're behind where they should land. And again, the peaks are not bad. They've got decent amplitude to them. There's decent peaks there, but they are slow. This retina is showing signs of stress. It's not firing like it should, signs of stress. And again, you validate this with the numbers there going, look at it. 100-yard dash, this is slow, 100% and 98 and 100% in the left eye. It's about as slow as it can get. The weightlifting competition, it's not bad. It's in the green there, in the 30th percentiles there, still within the normal range. But yeah, this is an abnormal ERG. There's some retinal dysfunction here. There's some retinal stress going on, and this patient is more likely to progress there. Going back to that, let's go back to the Flickr 16. We go back a couple of slides here. There was the question on right there. Yeah. Which one do you look at, the fundamental waveform or the actual waveform at the bottom? The fundamental waveform, kind of the computer smooths out the data and things like that when you're interpreting this. Bradley, I don't know about you, but I really focus on the bottom ones, the bottom left plot and the bottom right plot. Again, right eye and left eye. That's your actual waveform data. That's what I want to see. I don't rely a whole lot on the fundamental waveform. Maybe you do it differently. What are your thoughts?
No, I agree. Yeah, my eyes automatically go to the bottom right, bottom left, and look at the actual patient's individual waveform.
Yeah, the fundamental is just kind of a computer-generated smoothing out of the waveform, so you can kind of see a summation or an average of what it kind of would look like. I like the raw data, so that's why I look at the bottom there. So, yeah. All right, let's move on.
One more question.
Yeah.
So there's one that came in, I think it was on the DR assessment report. It says the right eye amplitude is about 20 and the left's about 10. Doesn't that seem abnormal?
Are we talking is it this one, the right eye?
Well, I'm trying to guess. The question doesn't say which report it was.
So I'm not seeing that.
I'm not seeing
this
20
one. Your
or
amplitude
10.
is the last one. And this one here
was the last one.
Yeah.
All right.
So the
yeah.
The amplitude is 20. You said the amplitude, right? It's like 22
Yeah, it
to
says
26.
the amplitude is 20 and the left eye is about 10. And Dr. Lydon, if you want to just unmute yourself, you can probably ask this yourself better than I can reading your chat.
So I'm seeing the amplitude of 15 and 18.1 in the left eye, and 22.5 and 26 is kind of your raw data. And then I look at the percentiles is mostly what I look at for this, and we're in the 50th percentile, so right in the middle of the normal range for the right eye, and again low normal, 12th to 14th percentile in the left eye, depending on whether it's the bright flash or the dimmer flash, the 16 or 32, which it does both. So again, to me everything makes sense here, Dr. Grant.
Yeah, I agree. I kind of look more at the numbers in the percentile, but still, it's within the normal range, just low normal left eye, middle of the bullseye, right?
Okay. Moving on. We went through that again, detecting, predicting, following, monitoring. We're going to go through this in the cases here. So let's move on. I think we're ready for our case number 1, Dr. Grant.
Absolutely. Yeah. So this is an interesting case where we were able to actually perform this test multiple times. And so it gave a very good picture of disease progression, and thankfully in this individual, disease improvement. But it highlights a few of the DR assessments and helps us to evaluate how we break those down. So this is a 67-year-old white female. We started seeing her about 5 years ago. It was one of the practices that we had acquired when she came to us. She had been insulin-dependent diabetic for a little greater than 10 years. You can see her systemic medication. She also had a history of glaucoma, was not diagnosed by us, and actually prior to us taking over her care, she had already had SLT performed in both eyes. I know that is near and dear to Dr. Lighthizer's heart, so I wanted to make sure I threw that in there as well.
There you go, buddy.
And so based on her diabetic status and retinal appearance, again, we first started seeing her in 2022, but we had not acquired the RETeval device at that time. You can see fundus photos here. If you look primarily inferior to the optic nerves and a little bit nasal in both eyes, there's just some scattered dot hemorrhages, couple cotton wool spots, maybe a little bit of exudate nasal in that left eye. Again, this is classic for moderate non-proliferative diabetic retinopathy in both eyes based on our current grading systems, which are all structural based, right? Your ETDRS and your DRSS are all based on structural anatomical findings. And we talked about the Mary Tyler Moore Vision Initiative. Again, we're angling towards including functional testing in our grading, but right now it's just anatomical, and that's where we come up with the moderate. So next slide, we had performed subjective functional testing. When we have individuals with active retinopathy, we do perform visual field 10-2 testing usually every 6 months. This is her most recent visual fielding, and she has some retinopathy, nothing crazy on the actual visual field test, maybe a little bit of central sensitivity reduction, decibels just a little bit lower centrally, but nothing that's a major reduction in functional vision on the visual field. Next slide, we've done OCT testing many times on this individual. We have August 2024 here on the right, February 2025. August 2024 on the left, February 2025 on the right. No CSME, no DME, either eye since we've been seeing her. So she has moderate NPDR. Once we acquired the RETeval technology, then we were able to actually place a number and a value on the risk that she has for progressing. And when we say progressing, we talk about the studies. What we mean is progressing to proliferative disease, right? When we talk about the predictive value of a DR score greater than 23.5 or a predictive score of a DR score greater than 26.9, it's high risk for progressing to needing retinal care, whether that's injections, focal laser, PRP, within 12 months. And so that's what we're being able to assess the risk for. So first ERG was performed in August 2023. Again, moderate NPDR, no DME OU. And she's a below 23.5, 20.2 in terms of the overall DR score assessment. You can see as we evaluate the actual waveforms, her amplitude is fine in both eyes, right? But you can see that she is slow, but not low, right? She's a little bit slow on that 32, where she's in the we're 98th percentile, but just glancing at it, you can see that it's in the red and outside of normal range in terms of her her latency in both eyes. And so 20.2, again, we don't have an actual defined risk assessment, but we know that's not in the teens. And our conversations with the patient at this point in time, again, her A1C is 7.4 at this visit. Our conversations are, look, this is a baseline test. We can see anatomically with the photos that we've just gone over that there is some bleeding in the back of the eyes. There is some anatomical changes. And now we can actually see that there is some stress. And so this means you are at an elevated risk for vision loss, right? And I think that sometimes we maybe get caught up in how am I going to evaluate the test? How am I going to explain it to patients? And I think we keep it as simple as possible to patients and say, look, there's stress there, and that stress could result in vision loss. Dr. Nate, I'll have you jump in here. How would you describe this ERG to a patient?
Yeah, I would describe this as borderline low normal. It's not a terrible result. Certainly, it could be much worse than this. I'm not terribly unhappy with this, but we're not showing a perfectly normal ERG either. And again, this is giving me what I would tell them and really emphasize this, utilizing this with your OCT and those fancy photos we took. This is giving me the best possible information and a complete picture to give you the best report and the best advice, Mr. Jones or Mrs. Jones. So I'm looking at this, and again, I'm going to watch you closely. This is not anything to panic about. It's low normal. I'm saying normal, borderline. It's not crazy abnormal, but we're going to watch this over time. And now we have a baseline number that if this goes from 20.2 to 22 to 24 and down the line over the next couple of years, now we got a problem, and we can jump on it sooner if we see that downhill slide for, again, 20 to 21 to 22 to 23, whatever it is. But hopefully we'll remain stable. But this is, again, your EKG of the back of the eye, and you want to know your EKG for a complete cardiac picture, and we now have this ERG for a complete retinal picture. So that's what I would spend that 1 minute that I just talked and just tell them that here it is. We're going to repeat this. I would repeat this probably in about 6 months is what I would do. And once we have stability, we could go to every year, but I would repeat this in about 6 months. That's how I would explain it to them.
Right. You must have looked ahead on the slides. We saw her back in 6 months. And one of the things I really love about this test is that I think it improves the conversations with patients. A small early Christmas miracle is that we saw her in August 2023 and we asked for 6 months and she came back in February 2024, right? Exactly at 6 months. And those of you who are in, chronic disease management know that that is extreme value in and of itself, right? So we repeated the ERG. We're still about the same in terms of that slightly abnormal, a little bit slow in terms of the latency, flagged on those lower left units there. But look at the DR score, and it's a little bit better. It's 19.2. So we've had some productive conversations. Obviously, encourage her to continue aggressive blood sugar management with her endocrinologist, and we're seeing that score trickle down. What was her A1C at that particular visit? Again, this is real life patient, private practice. She came in, she didn't know. So we didn't write it down. And that's how it goes sometimes.
Yep.
So again, she still has non-proliferative diabetic retinopathy. She still has anatomical changes. We're going to continue to watch this every 6 months. So next slide, we see her back again in 6 months. And we have a year difference between the two visits, baseline and now this one. The A1C has improved from 7.4 to 6.7. So she does have better systemic management of the condition. And you can see based on the DR score, that has continued to improve. And even our latency on those bottom numbers has continued to improve as well. And so what I like about this case and about, this patient was that one, it justifies the accuracy of the test where we can see improvement in systemic condition corresponding with improvement in retinal stress. And I think that it really delivers value for us to have conversations with our patients. And I don't have any data for follow-up improvement once we've integrated ERG technology, but I can tell you that I think from a qualitative standpoint, it does increase our patient interactions and our compliance with recommended follow-ups. And so we're going to continue to see this individual every 6 months. You can see there we're going to do, DR assessment every time that there's active retinopathy. We're going to rotate between macular OCT and fundus photos at those 6-month visits. Those of you who are in the coding billing world know that we have to rotate those to get them covered. But again, I felt like this allowed us to really watch that stress as it was associated with her systemic condition. And as she improved, it improved. And we were overjoyed to be able to tell her that.
And Bradley, I did not review this. When I knew this was your case, so I love to be able to be surprised and just go through this case as everybody else is. So I did not know what the answer was because we all do things a little bit differently. So let's interpret it in real time. Let's make our decision in real time. So we just happen to agree on this one. We may have disagreed on the next one. So there's lots of different ways to do this. But don't you think this puts you in the best possible position to make recommendations and to educate your patient? At the end of the day, that's what our job is in chronic long-term disease. Preseptal cellulitis, you put them on an oral antibiotic and a week later it's cured. This is a marathon of years and decades of this patient, and having the best tests available, the most complete picture, I think it makes me a better doctor. What do you think?
Yeah, I would agree. And, we obviously, every time that we see this individual, this individual and any of our diabetic patients, we're sending a letter to their endocrinologist, to their primary care. And I do get asked a fair amount, well, what if, that specialist doesn't know anything about ERG? And the fact is they don't. And that's okay, right? They're going to be reading the letters that we send based on, they're going to skim through and look at assessment and plan. And we're going to put a little blurb in there in terms of, indications of retinal stress or indications of, normal. And so as long as we're communicating enough to where they can understand it, enough to where they know that we're looking and we're on top of it, I think that's where the value lies.
Yep. All right. So I think we're moving on to our last case in our last, 5 to 8 minutes here. And again, we just saw a case that was, borderline low normal, but stable and improving over time, which is wonderful. Let's look at the predictive value of combining, again, diagnostic technology. So this next case is 39-year-old Caucasian male, type 1 diabetic for 18 years. He's got a bolus insulin therapy via an insulin pump, last A1C 6.4. He's got a wide range of A1Cs from 6.4 to 12.7, continuous glucose monitor. You can see his systemic medications there. Again, type 1 diabetic, 39 years old, hopefully has a lot of years left. So we got to get this one right and give him the best possible information in this type 1 diabetic. Mild NPDR at baseline. Again, first visit, November of 2023. Again, relevant family history, we got some glaucoma, no ocular meds, surgeries, or procedures there. Again, mild NPDR at our baseline exam in November of 2023, okay? And you take a look, and again, yep, mild NPDR, no venous beating, no IRMA, no NVD, no diabetic macular edema, scattered microaneurysm, scattered MAs, again, to the level of mild NPDR, normal, best corrected 2020, as you'd expect. Again, mild NPDR, okay? Here we go. OCT, yep, 2020. He's seeing 2020, OCT 2020, OCT angiography. You take a look at OCT angiography, and certainly you can see some areas of non-perfusion here, an irregular, enlarged foveal avascular zone. No evidence of IRMA, no evidence of PDR, but there's some areas on this OCTA that concern me. Again, these areas of non-perfusion. Couldn't see them with the fundus photos. That's why we do different testing. Again, whether it's ERG or in this case OCT angiography, this picks up something that I didn't see with OCT or fundus photos. So the OCTA, little red flag there. We move on to the ERG. And again, I'm going to pause here. I'm going to let you guys digest this ERG. Normal or abnormal? Overall, take a look. We went through interpretation. Normal or abnormal? Hopefully, quickly you recognize this is obviously an abnormal overall ERG. Look at the number, 25.5, but then look at the waveforms. Yeah. Are these waveforms low? Are these waveforms slow? The answer is yes, isn't it? They're both
look at the pupil
low.
Too. Goodness.
Huh?
Look at the pupil too.
And the pupil's not responding like you'd expect it to. So it's low and it's slow. It's you take a look and you're really slow in the milliseconds, 96 to 99th percentile, 91st to 98th percentile, flagging most of them. But even the strength, your weightlifting competition, you're at 11%, 7%, 15%. This is a weak ERG. This is an abnormal ERG. And when you have an overall number in the 25s, again, 25.5, the chances of needing retinal intervention, laser or vitrectomy or an injection in the next 36 months is high. Again, remember, this is November of 2023. November of 2023, mild NPDR, OCT looks perfect. If you didn't have OCT angiography and you didn't have ERG, you're not going to be on top of this as much as that OCTA and the ERG is showing you as well. So we've got some stress here, reduced implicit times again. And what are you going to do? This is the slide of, okay, how does this change anything, Bradley? How does this change anything, Nate? Well, I'd like to think if Bradley's cardiologist, did an EKG and it came back significantly abnormal or just abnormal in general, he or she probably wouldn't go, whatever. Well, we're not going to change anything. We're going to see you in a year. You'll be all good. You'd be like, what? They're going to change the follow-up. They're going to see you more closely. They're going to educate you better. They may do additional testing. They may start you on a medication, things like that. So this patient, instead of being seen in maybe 6 to 12 months, is now reappointed in 4 months. Better education. Again, that mild NPDR, no macular edema, that doesn't flag me. That'd be see you back in a year. But the abnormal DR score and the abnormal OCTA says we need to follow this patient closely. This patient has a high likelihood of needing laser or injection within the next 3 years. So reappointed in 4 months. So was the ERG correct? As you follow this patient over time, these photos are not the best, but showing, okay, is there areas of some hemorrhages here? And go on to the next slide here. And again, November of 23, seen back in 4 months, March of 24, and now you're seeing areas of neovascularization of the disc. The OCT angiography showing that degree of capillary dropout, and the ERG especially showing that 25.5, that's telling you, doc, this retina is ischemic. This retina is not in a good state. It is struggling, and unless we have intervention, maybe it's blood sugar, maybe it's A1C, it's diet, it's exercise, it's nutritional supplementation, not smoking, controlling comorbidities. We don't have that. They're going to develop some neovascularization. There's a high likelihood of developing proliferation. So in this case, the OCTA and the ERG were exactly right and were predictive of this patient having a higher chance of going to proliferative retinopathy. So using them together, very predictive in these cases. So hopefully this highlights the case that Bradley talked about and the case that I talked about. Use this and do this again. It's not a one-time thing. Follow this over time. And is there stability like in Bradley's case, or is this going to progress? And we're seeing progression there. So early detection, progression, improvement. Bradley, it's fun to watch improvement, isn't it, in these patients when they come in and I was a 20 and now I'm an 18 or a 17. They love that.
Right. Yeah. They love, I mean, um, they become more invested in their care in that way, right? You know this with glaucoma patients, they want to know what their pressure is. They want to know what their pressure is, and maybe they overemphasize what their IOP is. You know, I think we'd argue that, but it gives them another number that they want to know. And so we've had the device now for multiple years, and so many of our patients have had multiple tests, and again, they very much enjoy hearing how they're doing. And there's no more enjoyable conversation than letting them know they're better.
Yep. All right, next slide. I think is that the last one? I can't remember. Oh, don't forget, Dr. Chris Wolf has a course, a how-to course from an ERG user. He is an ERG user, how to implement this into private practice, when and why to order, how to bill this correctly, 92273, the applicable ICD-10 codes, revenue, ROI. Bradley, you've taken this before, correct? Highly
Correct.
recommended.
Yeah, it's an excellent course. Again, normally it's $299. There's a coupon code there on the bottom, and you can access that course for free. It's broken down into multiple modules, so you can kind of focus on one area at a time. But in terms of understanding the technology, but also implementing, right? Anytime you bring in a new device, there's always getting staff on board. There's where do I put it? There's when am I going to do it? How are we going to, teach the front desk to know that test needs to be ordered before the doctor sees them? All of those different things are covered in this course. And so really it's an excellent knowledge base that Dr. Wolf has put together for us. So I highly recommend it, especially it's tough to beat that price.
So
moving
doctors,
on.
two more questions in the chat that we should address before we sign off for the evening. One is on a new patient, since you are doing this before dilation, you find no diabetic retinopathy after DFE. Are you billing this normal ERG?
Bradley, I'm going to kick that to you. I'll answer the second one. In academia, we do this for our students and residents, educational benefit, and to get to baselines. You might do that differently in private practice.
Right. So the scenario was test is done before dilation, on evaluation, no retinopathy.
Right.
So I'll tease that out a little bit. One, if there's not diabetic retinopathy, it doesn't necessarily mean there isn't a billable code. So the 92273 is the code for the test. It doesn't mean there's no different code for the DR protocol versus the other ones. So many times, if there's no diabetic retinopathy, there might be some hypertensive changes. There might be some venous engorgement, which is vessel tortuosity. There might be some things that are billable, and so we make sure we document those, and we would bill it under that ICD-10 code. In certain cases, it is just normal, and so again, this is why it's up for debate in terms of certain doctors might do this on every diabetic. Some might wait and do it after they see retinopathy. But the times that we do it for just any diabetic patient, again, that's a medical exam. And so we're submitting the exam and the test to the medical insurance. If the only diagnosis that exists is E1 1.9, diabetes and no ocular manifestations, we're still going to bill it, even though we know that it's likely not going to be covered. And then based on what the insurance EOB says that the patient owes, the patient receives a statement for that. Again, offices that have said, this is a technology that I highly believe in, that I want that baseline data, and I want that for my patients if they're diabetic. That's one school of thought. Others, again, might say, I'm not going to do it on every single diabetic. I'm going to make sure I'm doing it on anyone who I've documented previously as having some form of retinopathy. So again, no right or wrong answer there, but like I said, it does come up, and in that case, we bill it and run it through the insurance and see where it goes.
Carrie's question is very similar to that. Diabetes, if they have diabetes without visible retinopathy, maybe they have reduced vision. Maybe they have a subjective visual complaint, something. They've got nighttime vision problems. They've got glare issues. That's a subjective vision complaint, decreased vision, either subjectively or objectively, or a prior abnormal ERG. I mean, in a private practice clinic, if you have a diabetic, let's say you have a diabetic that's been diabetic for 13 years, and they come in and they're 20/20 plus in both eyes, and their A1C is 6.8. They have no subjective complaints at all. Their vision is sharp. Their A1C is controlled. They have no complaints. And this is the first time you've ever, maybe it's the second time you've seen them, recently, and they have no retinopathy, no history of retinopathy. You might not run it then. You might wait and you dilate them, and then it looks good. Their vision's good. There's no history of retinopathy, and you may not run it. I still believe in at least having a baseline, but you probably can't bill that one, or you can't at least get paid for that one if they have no retinopathy, no subjective complaints, their vision's great, things like that. But if you run it and they have a borderline one or an abnormal ERG, now you have an abnormal ERG code that you can link all future ERGs to that abnormal ERG. So, every patient's a little bit differently. I tend to run ERGs in all of our patients because we're a school, but in private practice, I might limit this to patients that have a history of retinopathy, subjective vision complaints, their vision is down, they're uncontrolled, or something just saying, I think I need this data in this particular case. So.
If I could add just a little bit to that, I would say just to put some mathematical significance to baseline and progression. Again, the same study that showed that a DR score of over 23.5 created a 67% risk of progressing to proliferative disease, also showed that with a 3-point increase in the DR score, you double your risk. Okay, so each 1-point change is a 28% increase in risk. And so there is great value in establishing that baseline because there is a mathematical, and it's not really linear, it's more parabolic in terms of how it increases if your DR score is going up, but there's great value in that. And then the second thing I would say is if you're on the fence about integrating the technology, I wouldn't get terribly caught up in worrying about, am I going to be seeing diabetic patients without any retinopathy and never be able to utilize it? One, I don't think that that's likely going to show up that much in your clinic. That's the minimal patients that we see. But if you feel most comfortable saying, I'm just going to run it on those who I know I have retinopathy, my prediction is that once you get used to running the test and you start seeing the value that the test provides and the care that it enhances for you, I think you're probably going to rethink your integration and probably start running it on more individuals. But again, I wouldn't get too hung up on the outliers of those that may not be covered. You would be acquiring this technology because you want to elevate the level of care that you can provide in chronic management of this disease, and everything else usually falls into place.
I love this question by Ted. Would it surprise you to have significant hypertensive changes in the retina of an uncontrolled diabetic, yet still have a normal DR score of 17? That's a great question. And that is so clinical, something that we see all the time. And you look at this, I'm looking at the next one. That must be a different case. Would it surprise me? A little bit in a pleasant direction. I mean, I am pleasantly surprised. And to me, that is valuable data that's telling me we've got hypertensive changes in an uncontrolled diabetic, but yet the retina is hanging in there and the retina is still very functional at this point in time. And I like that. And to me, this is wow, the body is an incredible thing. The body is an adaptive thing. So that is useful information going, despite the significant hypertensive changes in an uncontrolled diabetic. You didn't mention diabetic changes as well, so I'm assuming they're uncontrolled diabetic without diabetic changes. A DR score of 17, does that surprise me? Yeah, in the pleasant direction. And it gives me okay, this is more likely going to stay hopefully stable, and this patient will not go seriously south. That's how I would interpret that. Any difference there, Dr. Grant?
No, I mean, no, it certainly would surprise me. I guess the question I would have is what's the patient's age? Again, part of the DR score calculation is the patient's age. So a younger patient is going to be able to withstand a little bit more stress before we start to see anatomical changes. Potentially that's it. I mean, but yeah, it would surprise me if there's significant retinal damage to see a normal ERG.
And I think they passed along actually the pictures if that's the same exact case. And again, you think of ERG, if those two, it is okay. You look at that, that's a very interesting case there, and you actually have the fundus photos in front of you. And again, I think this goes back to focal versus widespread. Focal versus widespread. I mean, yeah, you got significant hypertensive changes there in an uncontrolled diabetic. But remember, this is testing everything, the totality of the retina. And I think that's at least in part why we're seeing what could be considered a normal ERG. However, I would look, you dive deeper into this, and the DR score of 17.8, it's a pretty weak response in the left eye. Look at the amplitude, definitely reduced in that left eye. And even the right eye is very low normal as well. The speed is not terrible, but, that's why every one of these is different, and we have to be the doctor. And the DR score is 17.8. But I look at this going, this is still not a normal ERG. This is especially abnormal in the left eye and low normal in the right eye. Dr. Grant, your thoughts?
So I'm not seeing the images that you are. I don't know if I'm.
Oh, okay.
Yeah, but yeah, I would. I mean, the way that you describe it, I do think that it's valuable when you're interpreting the ERG printouts, is that you're evaluating the waveform and the pupil response and the actual raw data, not exclusively the DR score, right? There's value in that. And again, this patient sounds like they're kind of on the lucky end of the spectrum, but they're also standing on the tracks and the train's off in the distance. They probably want to think about moving.
Yep. How valuable is the test for AMD? We didn't really touch on that. I am currently not utilizing this for AMD. Again, AMD, may be considered more focal disease, macular area, and this is again a flash ERG that's overall retina. I don't think the research is quite there yet for macular degeneration and the use of a flash, a flicker ERG. Certainly there for diabetes and diabetic retinopathy and glaucoma and other retinopathies. I just don't think it's quite there yet. So we're not currently utilizing this in macular degeneration.
All right. Any other questions? Awesome. Well, thank you everybody for spending your evening with us. We hope you found this valuable. We will be sending an email with the recording to you. It'll go out probably later tomorrow. If you do have any questions, there's some information on there. If you wanted to reach out to a sales rep because you have other questions or whatnot, please do so. Drs. Lighthizer, Dr. Grant, thank you for this evening. Dixie, thanks for your time. And again, I hope everybody found this valuable, and have a good rest of your evening. Thank you.
Thanks, everybody. Enjoy your evening.